Chapter 9, Therapeutic Communication and the Clinical Interview. Okay, these are the terms you need to be familiar with, along with a handful of other terms we're going to be going through and that you will see over these slides, and techniques of communication. So first off, some of the objectives we're going to be working on are describing our communication process, working with environmental factors and our personal factors, discussing the difference between verbal and nonverbal communication, and learning how to attend to communication. So to just start off with, on page 139, we have our communication process, and you do need to understand this. Because there has to be a stimulus, a need to communicate in the first place, whether it is a need for information, to provide comfort, to ask for comfort, to give advice. There's got to be a stimulus, okay? A need, something's there to stimulate the communication, okay? Then there has to be a sender, somebody that initiates this. The message that's being expressed or being sent, the channel, the avenue of which you're sending the information. Here, it could be verbal, so you're hearing it. It could be a visual. It could be a touch. It could be a smell, you guys. Think about this. Think how many times you have come across somebody who has body odor, who has not bathed in days, or has worked out very diligently, and so they have been to the gym and they have exercised very hard. They're sending you a message, okay? And then the receiver, the person who is to interpret and respond to that feedback of that information that is happening, okay? So when this information is being sent by that sender, there is going to be filters that is being sent that are personal filters. This person's agenda, their goal of what they're wanting to send, their own biases, their relationship they have, their culture, their past experiences, their current mood and attitude, their value systems, their knowledge, their ability to relate or not relate to others, environmental factors, their gender, their role that they play, all are going to affect how they're sending their message. So then that message gets sent, right? Okay, so it's being sent. So they're nonverbal, their body language, are they tactile? Are they their body odor? Are they using silence? Is their verbal language and their nonverbal language congruent, matching, or are they contradicting each other in non-congruent term? Okay. Then the next thing is the message being influenced when it's being transmitted? What's the environment like? Okay. Is it noisy so that you can't hear them? How clear is the message or input that it's being sent? Is it being sent through somebody else? Have you ever played the game of telephone? And that by the time it gets to the final person, the message it isn't the same as what was initially sent or how it was being sent. Then it gets to the person. And remember, the person, the receiver, has their own personal agenda and goal, their own biases, their own personal relationship with that person, their own culture, their own past experience, their own current mood and attitude, their own value system, their own knowledge, their own ability to relate with each other, environmental factors, their own gender roles that they play. So all of these things factor in on how that message is received. From that, now we're going to formulate feedback. That receiver now is going to respond and send that information back. They can agree with that messenger, they disagree, they need clarification. What do you mean? They provide information, they request information, they get feedback, and that feedback can be verbal, they can make a face, or nonverbal, they can do both. So all of this information is going around in a big circle. So you are a new nurse in a psychiatric ward for an adolescent. Noah's your first patient. He's depressed. He has fresh cuts on his wrist, which is why his mother brought him in to be admitted. Okay. While taking his pulse, you notice that Noah has a number of old scars on his arms. When he sees you looking at them, he shakes his head and whispers, "Yeah, well, it's going to keep happening." And he's whispering that very quietly. So I have some questions to you. You need to now know what this patient is saying to you and the purpose of his message. Okay? What is he really trying to tell you? Why is he whispering this to you? Okay? What's the meaning of him putting his shaking his head? What are you thinking when you see all these cuts? He saw you with all those cuts. You must have had a nonverbal communication to him for him to make that statement to you. What is the meaning? What's the intentional, non-intentional communication that's going on there? Do you need to clarify and make clarity so that you both understand what you're saying to each other? What's the theme? What's the connection that it's taking place here? Noah's whispering statement of, "Yeah, well, it's just going to keep happening," does not involve which of the following. So is it he channeling? Is it stimulus? Is it a message? Is it feedback? So 3 of the 4 it involves. Which one does it not? So feedback, is he providing by a person receiving Noah's message after it's being interpreted and responded? It's not. That is what no feedback has been given to him. Okay? That's what the nurse is going to do. We're going to be providing that feedback. Noah's statement implies a desire to be understood. Okay? So Noah is sending you a message. Here's the stimuli that's there. And his need is to communicate for another to provide comfort or advice. He's sending his message through auditory channels, and he's whispering this statement to you for you to only hear. He doesn't want everybody else to hear this information. So personal factors that affect factors that affect communication. I've talked about this. Personal, the environment. So we've already talked all the personal. The environment. Where are you at? Who's there to hear? How noisy is the environment? How large is the environment? Is it a safe place? Is it an unsafe place? The relationship. Do you know this person? Do you not know this person? What kind of a room is it? Okay. The relationship. What kind of relationship is this? Is it a professional? Is it a personal? Is it a parent-child relationship? Is it an authority figure relationship? Words. Okay. Some things you need to know. A person can only speak 120 words a minute, but you can hear 420 words per minute. What are you listening to? When you communicate, you are communicating your beliefs, your values, your perceptions, your meanings. So how are you doing that? Is it through your tone, your pitch, the emphasis of certain words? You get louder, you get softer. How are you communicating? Is it your nonverbal? Is it when you reach out and touch somebody? It's all those things. You can convey interest and understanding, and you don't even have to say a word. By leaning forward to somebody, by touching their forearm, by making eye contact. Sometimes when I know a patient likes their coffee a certain way, and no one ever seems to get it right, I don't even ask the patient if they want a cup of coffee. I may go ahead and fix it and bring it and just give it to them. Showing interest, showing understanding. It's part of that customer service experience, but it's letting my patient know I get it. You can also insult and judge somebody through your verbal communication. You can clear or cause conflicting messages. You can be honest or distort feelings. So you have to decide how you're going to communicate. Because if you distort feelings, if you give conflicting messages, can you be trusted? Are you the person the patient's going to go to because they know you're going to be there for them? You're going to tell them what's up, how it's going to be. Are you that person they can trust? That is something very important to a lot of patients, especially in the land of psych. But what about med-surg? My pediatric patients growing up, when I'd have to go and start an IV, my patients will go, "Oh my God, here comes Teresa. That means you're going to be getting a shot." But you want her to give you the shot. She's good at them. She's going to tell you the truth. But you know that the treatment's going to come. But she's going to make it quick and it's going to get over. So it's a little bit of a love-hate relationship when it comes to some of those things. But my patients also know that I tell the truth. I'm not going to lie to a 3-year-old and tell him it's not going to hurt. Mom and Dad would like me to do that, but I'm not going to do that. It's going to smart. It's going to hurt, but I'm going to make it as fast as possible. But those are those kind of things that you need to do. Nonverbal communication. Okay, so that's that tone of voice, those emphasis of words, your physical appearance, your facial expressions, your body posture, the amount of eye contact, your hand gestures. Are you standing up straight and walking proud? Are you slumped, shuffling your feet, looking insecure? How do you present yourself? How do you present yourself as a student nurse when you walk into your hospital clinical setting? You may not know it all. Everybody knows you don't know it all. But you know what you do know, and be proud of that. You're going to learn. Be proud of the fact you can learn and you're willing to learn. So don't hesitate. I can learn. I can get this. That's what you need to walk into. It's not a false confidence. It's a reality. Now, verbal and nonverbal communications. Messages can appear to be one thing when in fact they're another thing. That's that false confidence. Okay? That's that message when everything's going to be all right, everything's good, when in fact the patient's dying. Okay? And you're hiding it, that everything's good. Now sometimes there are situations when you need to stay calm. You do not need to panic, even though the inside of you is panicking. Because if your outside panics, you're not going to think straight. And you need to think straight, okay? But you want your messages as much as possible when you're really talking to your patients to be conveying the same thing. People are often less aware of their nonverbal messages and their behaviors. This is very true. So that nurse, when she saw all those cuts on that patient, Noah, did her facial expression go white and go, oh my God, but it went all over her face, but she didn't say anything out loud? Or did she stay non-judgmental on that facial look? You don't know sometimes what you do. You have to pay attention to what you're doing and get that, what I call the game face sometimes on. Verbal messages can be called the content, while the non-verbal behavior is the process. So this is why when we talked about the SOAPy note in our previous chapter, the S, the subjective, is what the patient says. The verbal is the content. The nonverbal is the process. So the patient says everything's just fine when their feet are bouncing and they're tapping and they're biting their fingernails and ripping them off while they're singing. Everything's just fine. When their nonverbal behavior is telling you, no, it's not fine. And their affect is sad and they're crying all while they're doing this. That's when it's telling me that it's non-congruent. The affect, the mood, and the speed is non-congruent to what the patient is saying. Okay? And this is different than what we call a double bind messages. This is a mutually contradictory message which gives given by a person in power. And the best way I can tell this is when, say, and I'll give an example because you're a student, and this is probably the best way to explain it. Say that you have failed all your tests, and your instructor says to you, oh, you're going to pass the class. You're doing just fine. Everything's good. But you failed all your exams. That would be a double binding message. Okay? Because how can you pass the class if you have failed all your exams? It doesn't work. Okay? So this is where I would go back and say to a student, you're at risk for not passing, and this is before all the exams are failed. You're at risk. You still have the potential to pass, but we've got to do some things differently now because your exams, you've got to pass the rest of your exams to make this happen. Okay? That's where you have to look at what you're saying, because that's the double binding message. How can you fail all these exams and I still tell you that you're going to pass? It doesn't work. So that's that double binding message. Everything's going to be just fine, even though you committed a crime and you're arrested. And how can it be fine? It doesn't make sense. So you have to be very careful about creating those double bind messages, because somebody's going to take them literally that it's going to be fine, and then they're going to feel like they've been lied to. So, which behavior from Noah would be considered a double bind message? Okay. He winks at you and says, do you date 15-year-old guys? He puts his head in his hands and shakes it and snaps, I don't want to do this. Just get me out of here. He sneers at you and almost purrs as he says, oh yes, I will tell you anything you want to know. Of course I will. He cries and shakes and jiggles one leg as he says softly, please, let's just not talk about Dad, okay? God, please. So which one is contradictory message? If you said C, you were correct. He's attempting to gain and maintain power. So now we're going to work on identifying the 4 techniques that can enhance communication, highlight what makes them effective, and identify the 4 techniques that can obstruct communication, highlight what makes them ineffective. Okay, so here we go. So these are our tools that we use to enhance communication. First, and you will find this on page 143 through 144, table, oh, before I do that, I did forget one thing. On nonverbal communication, you're going to find that on table 1.9 on 140. I did forget to tell you guys that. I apologize. So on these verbal techniques here that we're going to be using to enhance communication, they're on page 143 through 144, table 9.2. And it provides you some examples and descriptions. Definitely look over these. Don't be surprised if they don't show up on your exam with some examples where you'll need to recognize them. So we're going to start with use of silence. One of the things I want to discuss with use of silence is that it doesn't always work with children. Children is not an effective tool to use, and the reason behind this is children don't, what's the word I want to use? Children don't know it, their development of their language skills, to be able to reflect back and to have abstract thinking is not all there. So that silence does not necessarily have an ability for them to be able to go back yet and reflect back on their thoughts to be an effective device for them to use. But sometimes just sitting in silence, letting a person just breathe and just being there can be a very effective tool to allow a person to just contemplate, reflect, and then be able to talk. Okay. Active listening. Okay. This is where the nurse is fully concentrating and just listening to this person speak with their nonverbal and their verbal language. Okay. And that this allows us to then use our nodding, and then we'll go into using clarifying, paraphrasing, restating, reflecting, exploring questions with our patients, so that we are able to assist them in communicating with us. Okay, so giving that eye contact, nodding, just allowing that person to express themselves. Now, clarifying techniques, I just kind of listed through what these are, but this allows us to help understand and clear the communication so that we're interpreting the message the patient wants us to understand. There are times when a patient will say to you, I feel really doped up right now. Now, through your filters, doped up may mean that they feel groggy and under the influence of something. But the patient's doped up may mean that they just feel like this is whack. And whacked means this is weird, doesn't seem right, is not okay. And that's what doped up means to them. So you need to clarify before you interpret something incorrectly. Okay, so we're going to go through some of these techniques here. So we have paraphrasing, okay? So paraphrasing means that you're going to restate the basic content of what the person just said. And you can start it with, I'm not sure I understand, or it seems you're saying this, 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 and this, okay? Without restating the whole thing. And that leads us to the next one, restating. So restating means you're literally restating what the person said. So your life has no meaning. You restate what the person just said. My life is empty. It has no meaning. Your life has no meaning. You restate it back. Reflecting, okay, assists the patient to have better understanding of their own thoughts and feelings. You sound as if you've had many disappointments, would be a reflecting. So the patient is talking about all these bad things that have happened, that they've been let down. You sound like you've had many disappointments. Exploring. Okay, so now we're going to explore. So tell me more about, describe your relationship or describe this situation. Can you give me an example? Instead of can you, just give me an example. Let's talk about one thing that you did wrong or one thing you did right. Okay. There's times when you want to do that open-ended question to encourage that patient to explore. What did you do? What is an example of? Or sometimes you need to do a closed-ended to get a couple pieces of information you needed to elicit more information. That's just that what if, that yes, no kind of thing in the situation. So were you at home when this happened? Yes or no? So when they're telling their story or discussing something. Then you've got the projective question. Okay, a projective question has to do with what if. Okay, a lot of times when I have anxious patients and they're having lots of thoughts and feelings and we want to explore something, I'll give them a what if. What if? And so I have them. So what if this does occur? What will you do? What's the thing that will happen? So that they can work on maybe some problem solving. Okay. What if you had 3 wishes? What would you wish for? What would be different now? What would you do differently? And then there's the miracle question. This is for goal setting. Okay. What would your future look like if all your problems were to vanish and go away? And be really dramatic when you do this. Okay. Suppose while you were sleeping tonight, a miracle happened and all your problems were solved. Tell me what your world would be like. What would be your goals that would motivate you to pursue life? What would your day be like? What would your life be like? Okay, the miracle question. All right. Go through these examples. Look at therapeutic techniques of reflecting, focusing, exploring, giving information, seeking, voicing doubt. Go through these. Look at these examples, summarizing. There's a handful of them there. Again, eliciting questions, that open-ended question, those closed-ended questions. We've gone through these a few times now. So there's some non-therapeutic techniques, okay, that we want to avoid doing, okay. This is on page 149. These are issues that happen, and there is a table on 146 that are non-therapeutic. You want to memorize these because when they show up on your NCLEX, when they show up on your HESIs, you do not want to pick them. These are the top 4s. Anytime when there's excessive questioning, you don't want to keep questioning your patient. You want to have a conversation be fluid and flow, okay, like you're just having a regular conversation. But when you're finding yourself having to ask many questions, that's starting to get into excessive questioning. You do not want to find yourself giving a lot of approval or disapproval in your questions. You want your patient to define whether things are okay with them or not okay. Okay, you may want to have them explore, but you want them to come to the conclusion that this may be a bad idea. So, this is where the patient is saying they want to go kill somebody. Okay, now you know that it is not okay to go kill somebody. All right, but you don't want to be that person that's going to say that this isn't, well, you may need to be that person that says this isn't safe. Okay, this is going to harm you, it's going to harm somebody else, and you may end up having to have that conversation. But you want to be that person that's going to say, okay, so how does this really sound reasonable? You tell me. You sound very frustrated right now, and you sound like you don't have any other options. Let's talk this through. So instead of me disapproving of what they're saying, I'm reflecting back, I'm acknowledging how they're feeling, I'm hearing what they're saying. Okay, that's what you're wanting to do instead of approving or disapproving. Giving advice. We are not to give advice. That is a social relationship. So like, for example, a patient says, what do you think about this doctor? Now, in the back of your head, you would never have one of your family members go to that doctor. Now, you would look at them and say, well, this is one of our doctors on our staff. We have a lot of doctors. What do you think about this physician? Okay, and the patient says, well, I don't really like them. I'm very uncomfortable. Have you talked to your physician about this? No. Well, I think that would be a place to start. Now, you do have rights and that to be able to change physicians, and we can advocate if you'd like to do that. But I would start with the fact of talking with your physician about how you're feeling, and you can request to change to another physician if you so desire. So those are some ways of being able to handle things without saying, you have a horrible, awful physician. Okay, you don't, and you can't cross those lines. Okay, and then never ask why. It's hard sometimes not to, because you need to know why, but you don't use the word why. Anything but that word why to elicit the answer. Okay, so what brings you to feel this way? Okay, what led up to this? But not the question why. So there's a lot of components that happen that you will find yourself doing. So pay attention to when doing those things. So Noah has made it clear he does not want to talk about his dad. But the truth is, as the interview approaches, he becomes anxious and he tries to evade all questions about why he's here. Which type of communication might be most appropriate right now? Stopping all questions so much that he just give him some good advice so he'll trust you? Express honest disapproval of his resistance to help? Ask him point blank why he's evading you? Ask a miracle question. So if you keep pushing him, that's not going to help. You're going to elicit an aggressive response from him. If you give him disapproval, he's going to have rejection. Okay. If you ask him point blank, why he's evading you, I don't know that your relationship isn't a working relationship yet to really be able to do that, so that might turn him off. So that D question might be your opening, that miracle question, the goal setting, because you still need to figure out why he's here, and obviously dad is the issue. There must be something behind it. So let's go to the future. Let's set that goal and get that, see that patient to see that future, and what happens if the problems were to vanish. So while Noah's anxious about saying anything specific about what's troubling him, let's see what he can wish for the future. Okay, let's see if we can get him to open up that door and talk about what his future. So Noah, if you were to go to sleep tonight, we want to set your goal, and you were to wake up and all your problems were to be gone, and your future was everything is all the problems were gone. I want you to set your goal for your future with these problems all gone. What would your goals be? What would be tomorrow? What would your life look like? What would be happening? If they were all vanished? Could he answer that? That might be opening the door, and that can get your foot in to be able to discuss what's going on with dad. So now we're going to look at cultural components, the eye contact, the style, and we're going to talk about insensitive to cultural influence and styles, and also information technology. Okay, so this is all on page 147. And we've already also had our chapter on cultural component. So communication style. Do remember that depending upon what cultural elements we are, if we're dealing with somebody from an indigenous culture, not making direct eye contact, looking down and then glancing is more appropriate. Touching is not an acceptable necessary component. In handshakes in English, United States is very appropriate. In South America, Hispanic cultures, hugging, touching is very needed, being in close contact. Think about where you're at using your cultural filters. Make sure you're asking the appropriate questions when you're doing your psychosocial assessment and doing those cultures. Is it appropriate for you to do physical care of your patient, or is that something that the family needs to come in to do ADLs? For the patient, then make sure you check the schedule and make sure that there is a routine that is set up, that the family is going to be in at such and such time for doing it, so that there is no neglect going on. Make sure that there is no prejudice or bias that are going on when you're caring for your patients. Know what the norms are, so that you are appropriate. Some things to just keep in mind. If you are of Asian descent and you're first generation, possibly in the United States, and your family just came over, they revere somebody that is in the medical field. So if a nurse were to be giving a wrong medication to a family member and they knew that the medication was wrong, they're not going to speak up and tell you that you're giving the wrong medication. That patient will just take it and swallow it. So even though we teach and we pursue that the patient and family need to speak up, they will not do so. So we need to encourage and ensure that the patient and family speak up and do these things. Then in the sections, they talk a little bit about Native American, Japanese, Filipino, Hispanic. Take a look and make sure that you look at the little different components and look at those cultural filters, and maintain those. Okay. All right, information technology. We use a lot of we use telecommunication a lot these days, and with the COVID-19, this was a really good example for a lot of people. You guys may have personally gotten an opportunity to use this to help provide your own care. This is a way for us to interact with our patients and for long distances. When you live in rural areas, this is a way for us to actually have physical contact with our patients. But also we use this in our clinical settings, and we can roll it into our room and be able to type on while we're in the room with our patients to gather our information and see our data in front of our patients as we're looking. We can see our labs, our vital signs, live time, and be able to interact and track information immediately, so that we can see our information on our patient and look up their psychosocial history and be able to maintain that information on our patients. We'd be able to see them. There's good things and bad things with telehealth information, but we're able to move it along and be able to be very successful with this information. Okay, and we can track our data and any changes that happen and occur. We have mobile applications now to monitor diagnosis, treatment, and communications with our patients. We can use our phones, and for high rate issues, we can do EEGs, EKGs. We are able to quickly adopt apps to communicate where there's more research that's needed. We use SAMS uses research for resources for suicide prevention, bullying, underage direction, underage drinking prevention. On top of this, we also use this for staffing. We can do live things with census, with acuity, and be able to communicate live and very quickly to staffing needs, to the staffing department, from the units to actual employees, to obtain and achieve. Okay, so our objectives here is to talk about best seating arrangements, settings, to begin our interactions, attending behaviors a nurse might want to focus to increase communication, and explain to a classmate the importance of clinical supervision. Okay, so pacing. When we are talking about pacing, what are we talking about? We are talking about the fact of how to go about how fast we want an interview to go, how slow, how fast our interaction needs to be, when we need to focus in, when we want to slow down our interview process. So this is where do we have open-ended questions, closed-ended questions, the pace of the process. Our seating, do we want to be sitting across from each other in an authoritarian component? Do we want to be side by side? Do we want to be at perpendicular to each other? How do we want to be sitting? It depends what we need to accomplish. If I want my patient to realize that we're team members, I want to have it where we're side by side, where we can share information and see where I can have access to do a blood pressure cuff. So we want a little bit of an angle where we're doing a face-to-face but side by side, working together. What kind of chairs are we using? Are we in a group setting? And so we want it in a circular set. Do we want a table between each other? Do we need a hard surface to be writing on? What kind of seating arrangements do we want to do? Our introductions. Do I want to just introduce my name and their name, or do we want to also identify our roles so that we identify our roles and our purposes? What are we doing? How are we doing these things to help set this interview up? 120-degree angle. Do you want to be part of that, going back to the seating? Think about safety. Do you want to set the patient closest to the door, or do you want to set yourself closest to the door? Do you want to be set and trapped in a room where you can't get out if a patient becomes aggressive? Is there a panic button in your room? These are things you need to think about and consciously think about. And so I always set myself so that, and best practice is to set yourself so you're closest to the exit door, but also allowing your patient to exit out the door. But you should be able to have a quick grab to exit out the door, or to even be able to offer the patient a way out the door. So make sure you're able to see and provide that safe environment, and that it doesn't look scary or threatening. It's a non-threatening environment, okay? So make sure you are introducing yourself, okay, during that interview. And then start with a very broad question after you've introduced yourself. So tell me a little bit about yourself. What brought you here? What are some of your stresses? What's been happening the last few weeks? Let me know what some of your concerns are. Tell me about the difficulties you've been having. There's tactics to avoid. There's a little box that's on page 150. Things to try to do, things to try to not do when you're interviewing. These are some of the biggies. Arguing. Avoid arguing and avoid minimizing. Don't challenge your patient. Avoid giving false reassurance. It's going to be okay. What happens if it's not going to be okay? Interpreting or speculating. When you don't know, you don't know. So don't interpret. I don't have enough information to be able to tell you. We're going to need to find out more answers. Probing into sensitive areas that the patient doesn't want to discuss. This is where it sounds like this. I would say this sounds like a very sensitive area for you. And I'll leave it as an open question like that, where my patient will say, yes, it is. I really don't want to discuss it right now. Okay, it's something you don't want to do right now. I hear what you're saying. I do want you to consider maybe later on that that's something you want to talk about, but right now we don't need to do that. Okay. Trying to sell a patient on accepting treatment. When they're first, especially when they're first coming in, that's the last thing you want to do. That's just like shoving something down somebody's throat that they just don't want to hear. They're angry, they're upset. And even though this may be the best thing for them, this may not right now be the time to hear that. Right now, they just need to have you listen, to have an empathetic ear, and to hear what they're saying. Also, avoid joining in an attack about a patient. So maybe the other patients might be teasing a patient about something that they're doing or seeing or saying. Don't join in. That makes you an unsafe person. Usually what I do at that point in time is actually work on shutting it down, because it's a form of bullying, and you do not want to have that happen. And then participate in criticizing other staff members. Don't do that. You don't know what is going on. You don't know that patient's perception of what happened to what the staff member's perception is. And remember, there's always two sides to the story. Everybody has their own style of doing things, and it's okay to have different styles. We just don't participate in that. I work on coming up with options and solutions to the issue, and to turn it into a learning situation. So that, what if this person doesn't like how they did something? What can we learn from this? That's the takeaway from those things. That's what we want the patient to learn. So I'll get back to those attending behaviors. That foundation, eye contact, the body language. One of the biggest things is learning, especially with a lot of our psychiatric patients who have had boundary violations because of trauma, abuse issues. We know that there are personal space issues, okay? We know that public space is anywhere from 12 feet or greater is considered public space. And when you get in closer than 12 feet to somebody, you are now entering into social, okay? So public space is just gathering, and sometimes in public space, by the way, this can happen it happens all the time. Think about when you go on a subway or a bus. It is a public space and you're crammed in there and you are not 12 feet apart. Okay, you're actually in a personal to an intimate space at times, but it is a public space. So think about those times and those moments. That is still considered a public space. Social space is anywhere from 4 to 12 feet of distance. Personal space is 18 to 40 inches. Intimate is 0 to 18 inches. So now, when I'm talking about this, now let's take this even further, because what kind of relationship is an intimate distance? Parent-child, infant-parent, changing diapers, bathtub time, spouse, boyfriend, girlfriend. Okay, intimate. So also think about then what kind of things do you share on an intimate level? Think about the emotional intimacy, your secrets, the trust that goes with those secrets. So sometimes friends get on that emotional intimacy level. Then you've got your personal intimacy, personal distance on an emotional basis. Your social, your public. Now, when somebody invades through abuse, domestic violence, think about in 2018-19, the gymnastics physician that had invaded all of those gymnasts' personal, intimate, distant spaces. They were groomed from early childhood, some of those girls and boys. And they didn't know it was wrong exactly. Their hairs on the back of their head were standing up, but they couldn't be hurting me because, see, he's supposed to be taking care of them. So how could he do this? How can it be confused? And they start to get confused about things. It starts to mess with their relationships. And so then other people are allowed to enter into those intimate and personal spaces that shouldn't be allowed to be entering those spaces, because those boundaries aren't being set. And so we have to look at this, because this is how we start to tell, especially with children who've had those spaces invaded or have attachment issues, because they'll invade adult spaces and you're like, what is going on here? This does not make sense. You know, you shouldn't be climbing on my lap right now. This is invading a personal space that I'm a stranger, and you should have stranger danger, and you don't have any. Something's wrong here. Or maybe the child that's way too afraid. So keep that, and we'll talk more about that. But think about that personal space. But culture also will play in to registering those personal spaces. Voice quality, how you talk. Are you shouting, yelling? What is that? Attending behaviors. Clinical supervision. This is necessary. I've talked about this before. To work on your interviewing skills, to foster and growth of your professional development, to help minimize non-therapeutic patient relationships. You want to build your skills. There is nobody that is perfect. We always have to constantly work on our development of our skills. This is a necessity that we all have and will want to always continue to foster. Process recording. This is where we actually record our sessions with our patients and look at our verbal and our nonverbal skills. This requires us to get a release with our patients to do this because it is recorded, and we take a look at how we're talking to our patients. Are we leaning forward? How's our communication? How's our patient looking at being able to read the nonverbal skills and our verbal skills, at how we're reading our patients, and being able to reflect back on these things to improve? It's a very good, useful tool that we utilize. So here's a question. As a nurse assesses a new client, the nurse makes sure that the door remains open. Which type of communication factor is this? Is it environmental, relationship, or personal? This would be considered environmental. So now, when doing this door being left open is a safety issue. We're leaving this door open because there's a safety concern. Maybe it is because it's somebody of the opposite sex, and so we want to make sure that this person feels safe and there's no allegations of misconduct, or that maybe we're concerned that the person might attack. But at the same time we leave it open, then we have to understand that there may be background noise that may interfere. There may be a lack of privacy. It may cause some uncomfortableness that can cause issues. Okay, so we have to be aware that that could cause some deterrence then of how much the person's going to communicate with us. A nurse assesses a newly hospitalized client. Which communication technique will the nurse most use? Rapid, high-pitched voice tone, closed-ended questions, direct eye contact, frequent touch. Again, a nurse assesses a newly hospitalized client. Which communication technique would the nurse use most? So this is our first contact we're needing to assess. So we're going to go for that closed-ended question because we want to get as much information as possible, very specific at first, because it's our initial contact. So we go for the closed-ended, then we'll go pull for the opened